Good evening, everyone, and welcome to our webinar, Chronic Conditions Management, and this is an update for Allied Health. My name is Brendan Goodger, General Manager for Primary and Community Care here at Central Eastern City PHN. Today I'm joined by my colleagues from the Practice Support and Digital Health teams. We've got Grace Bicknell. Welcome, Grace.
Thank you.
We've got Amy O'Halloran. Welcome, Amy. And we've got Kayla. Welcome, Kayla. And I also have with me Dr. John Petrosi from Central Eastern Sydney Allied Health Network, and I'll introduce John formally a bit later. Firstly, I would like to start by acknowledging the traditional custodians and sovereign people, the land across which we work. I recognise their continuing connection to land, water and community, and pay respects to elders past, present and emerging. I would also like to extend that respect to any Aboriginal colleagues who might be joining us here tonight. In terms of some housekeeping, please note that this webinar will be recorded and will be available on Cessna's own YouTube channel within the next couple of days. At the end of the webinar, there'll be an evaluation survey. It'll pop up on your web browser. We appreciate your feedback. Please complete this to allow us to issue certificates of attendance. Please ensure that you submit your questions to the speakers in the Q&A, and we'll be carefully monitoring the Q&A. It's at the bottom of the screen. And to view this box, just hover over the toolbar and you'll see it. Now, look, firstly, I should introduce John, who's chair of the Central Eastern Sydney Allied Health Network. John has been a chiropractor for over 26 years, practicing in Leichhardt, and is also a postdoc researcher in the field of chronic musculoskeletal health. John's also a friend of the Central Eastern City PHN, and we're very glad to have him here tonight as part of the panel. Now look, tonight we've got a really fantastic presentation from Grace, and I'm really happy to hand over to Grace. Now Grace is our Digital Health and Quality Improvement Officer. Does a fantastic job. We're really lucky to have Grace here tonight. So Grace, welcome. The floor is all yours, and we're looking to learn an awful lot from you tonight. So go ahead, take it away.
Thank you, Brendan. Thanks so much. Hi, everybody. Today I'll be discussing the chronic condition management changes and the way these changes impact allied health practitioners specifically. By the end of this webinar, we're aiming to understand the recent changes to the chronic condition management, or CCM, which was introduced on the 1st of July this year, determine new minimum referral requirements, examine impacts on service delivery and patient access, demonstrate how to prepare for the transition and maintain compliance, explore opportunities to enhance the care coordination under these new models, and get a better understanding of the role of digital health such as PRODA, HPOS, and My Health Record in allied health chronic condition management workflows. So, first I'll start with, what is changing about the chronic condition management frameworks. Item numbers for GP management plans, which is GPMP, team care arrangements, which is TCA, and reviews will cease and will be replaced by a single item number for the creation of chronic condition management and the chronic condition management plans and review of chronic condition management plans. Chronic condition management templates and referral paperwork that your patients start bringing in may start to look different. Minimum referral requirements have changed, so names of allied health providers are no longer required to be on referrals, and names of allied health, the number of allied health sessions allocated by the GP is no longer required on the plans and referrals, but it can be included if the GP would prefer to. And allied health providers no longer need to confirm their agreement to participate in the patient's multidisciplinary team. So those are the big changes that are happening. What isn't changing are your allied health item numbers. You're still going to bill with the same item numbers for the services as before. Reporting requirements haven't changed. Reporting requirements for allied health practitioners to provide a written report back to the GP after the provision of certain services, like the initial and the final service on a referral, or when a change in the patient's condition or health needs are required. So that stands the same, and the number of sessions that are available to patients hasn't changed either. Still 5 sessions or 10 sessions for Aboriginal and Torres Strait Islander patients. So I want to touch on why these changes are happening. Why these changes are happening. So these changes to the chronic disease management framework are a result of a review by the MBS Review Task Force, which was informed by the General Practice and Primary Care Clinical Committee. A key objective of these changes to the arrangements for chronic condition management is to encourage regular reviews of GP chronic care management plans. The changes introduced were recommended by the MBS Review Task Force, and they aim to simplify and modernise the arrangements for healthcare professionals and patients, promote the continuity of care, encourage the regular review of chronic condition management plans, support communications between a patient's multidisciplinary care team, and ensure existing patients can continue to access the services that they need. So what the task force found, it identified that 30% of the team care arrangements that were billed did not result in the patient actually accessing the allied health sessions that they'd been referred for, and 55% of the previous 721s and 723s, so that's the GPMPs and the TCAs, that were written didn't receive a review. So in response to these findings, it was recommended that the GPMP and the TCA be combined into a single item number, which is the GPCCM, and the code for that one is the 956, and then for the review, having another item number for that one, which is the 957. They also recommended that the fees were balanced to be the same value. Previously, reviews were worth around 50% of the fee of a creation plan, whereas now both the creation plan and the review are worth $156.55. And another finding was that chronic condition item numbers were being billed opportunistically by other GPs that weren't the patient's usual ones, which didn't facilitate good continuity of care. So the introduction of MyMedicare promotes continuity of care by linking a patient to their regular GP for matters related to chronic health management. It's not mandatory in order to get a GPCCM, but it is encouraged. So let's talk about the changes to the chronic condition management documentation and referral process. So as you know, allied health practitioners were previously required to confirm collaboration under the TCA. However, as of the 1st of July, there's no requirement for allied health practitioners to confirm acceptance of the referral or otherwise provide input into the preparation of the GPCCMP. The step was removed to improve patient access to services and reduce red tape. Previously, the referral to an allied health provider was created in a form format. The referral provided by GPs will now be in letter format, as it is with other specialist referrals. This change was intended to simplify the referral process for GPs, allied health providers, and patients. The next change we have is that allied health provider names, specific names, are no longer required to be listed on referrals. Only the discipline needs to be listed. And previously, team care arrangements required GPs to allocate the number of sessions between each discipline in the multidisciplinary team. Both of these requirements have been removed. They were removed to provide the patient with greater flexibility regarding the access of services, as well as giving patients more autonomy over which allied health providers are involved in their care and how their sessions are used. So we know the referrals are changing. Let's discuss what the referral requirements are now under the GPCCM framework. So referrals from the 1st of July onwards, regardless of if they are connected to a GPCCM or a GPMP/TCA, like the old system, anything referred to you from the 1st of July onwards needs to meet these minimum referral requirements. So it needs to have the name of the referring practitioner. It needs to include the address of the practice of the referring practitioner or the provider number of that practitioner at that location. It needs to include the date on which the referring practitioner made the referral. It needs to be in writing. It has to be signed. Electronic signatures are fine. it has to explain the reasons for referring the patient, and it should be uploaded to the My Health record where patient consent is confirmed. So ideally having them uploaded to the My Health record. What has changed? So what isn't required on these new GPCCMPs? They are no longer required to specify the name of the allied health practitioner, as I said, and they're not required to specify the number of services. And again, they don't confirm the confirmation of collaboration. So I have some examples of what the new GPCCMP looks like. This one is from best practice. I've circled the item number at the top just because I do want allied health providers here to remember that the GPCCM is item number 956 and the review is 957. Because there is a transition period, some GPs might be using older paperwork or older templates. So we do want to make sure that where we can look at these templates and discern that they are the new ones and that the right item number has been billed, then we can use that information. So on this one, the referral, this is from medical director. This one just says GP CCMP. So you know it's the right template. And this is just the referral. So it'll go from looking like it does on the left, which is a form format, to just a simple letter. So in terms of service delivery and patient access, the timing remains the same with GPCCMs eligible to be prepared every 12 months, just the same as the GPMP and TCA. Reviews, the same, they can be conducted every 3 months. GPCCMPs don't need to be billed every 12 months though. They only need to be billed when a change to the chronic condition management plan is required. Plans on the GPCCMP can be reviewed indefinitely if there's no change needed. GPCCMPs also are valid for the time frame stated in the referral by the GP. However, if the GP hasn't listed a time frame, then it's 18 months from the date of the first service under that referral. So while GPMPs don't expire, the patient must have had a GPCCMP reviewed or prepared in the previous 18 months in order to access the allied health services. So if a patient does have a GPCCM billed after the 1st of July and they don't access the services under that GPCCMP for 18 months, they would need to see their GP again to either get a new plan or a review done before they can then access the services. So it doesn't expire, but it does need to be renewed. There's also an intersection with MyMedicare that I wanted to touch on because there is a push for focus on continuity of care and regular reviews of the GPCCMPs. MyMedicare also plays a role in that structure going forward. Patients who are registered for MyMedicare will need to access the GPCCMP from their GP at the clinic where they're registered. Patients who aren't registered at any clinic, they can access the GPCCMP from any GP. I wanted to also go through the transition period. There is a 2-year transition period for patients who have existing GPMPs and TCAs to come across to the GPCCMP, the new system. So I will just show you this case study here. So this is, in this example, we see that a patient has had a GPMP and a TCA billed prior to July 2025. They were referred for 3 sessions with a physio and 2 sessions with a podiatrist. You can see that the name of the physio and the actual clinic has been listed, same with the podiatrist. So for the patients that have had a GPMP and a TCA in place, have had one before the 1st of July, there's no immediate action needed. They can still access the allied health services under the existing GPMP and TCA, and they'll be able to access these services until the 30th of June 2027. Referrals written prior to the 1st of July 2025 will continue to be valid until all services under that referral have been provided. Patients who require a review of their GPMP or TCA after the 1st of July will need to go back to their GP, and they will be transitioned onto the GPCCMP, the new model, and they'll get a new care plan build, which is the 965. And letters to GPs are still sent at the usual intervals or more frequently if that's necessary. So just a reminder, from the 1st of July, any new plans put in place need to meet the requirements of the GPCCM. From the 1st of July onwards, you should not be receiving any new plans that have been billed after the 1st of July that are GPMP or TCA. They should be GPCCMP plans. Any new referral for allied health services should meet the new referral requirements that came into effect on the 1st as well, regardless of whether the referral is under a GPMP or TCA or under the GPCCMP model. Now I have an example or a case study for a patient who had gotten a GPCCMP billed after the 1st of July. So they have a new care plan build. It was billed after the 1st of July, so they're on the new system. The confirmation of collaboration is no longer required. The number of sessions allocated to each specialty isn't listed on the plan of the referral. However, the GP can choose to allocate the sessions and record it on the care plan if they choose to. The referral doesn't need to include the allied health provider's name specifically, only the specialty, for example, dear physiotherapist, dear podiatrist. And patients can access the sessions they're eligible for the length of time stated on their GPCCMP. Again, if it's not listed by the GP, if there's no expiry date listed by the GP, then it's 18 months from the date of the first service under that GPCCMP. Reviews can be done every 3 months if necessary, assuming there are no changes in the patient's health conditions, and allied health letters are sent at the regular intervals. Ooh, sorry. Okay, so the 2-year transition period. Oh, sorry, bad. Sorry. Okay, 2-year transition period. So patients with a GPMP or a TCA in place prior to the 1st of July can continue to access the services through those plans. Individual group allied health services can be accessed under the GPMPs and TCAs until the 30th of July, and medical practitioners can continue to create referrals under these plans. Referrals for allied health services written before the 1st of July will remain valid until all the services under the referral have been provided, and MBS items for reviewing GPMPs and TCAs ceased on the 1st of July 2025. If a patient requires a review of their TCA and GPMP after the 1st, they need to be transitioned onto that new GPCCMP model. So how have the chronic condition management changes impacted care coordination? So reporting remains the same, still to be sent after the initial and final session on that referral. Frequent reporting can be completed where it's clinically necessary. And reports should include the following: investigation tests, assessments, any assessments carried out, treatments that were provided, and recommendations on how to manage the patient's condition in the future. So what do you need to do to prepare? Read the Medicare CDM Allied Health fact sheet. I've linked it in this webinar. These documents come from the Department of Health, Disability and Aging, and it has information specific to allied health providers and their practices. From the 1st of July, be aware that you'll start to receive referrals to treat patients under the GP Chronic Condition Management Plan, the GPCCMP. GP software has released templates for these plans. However, just be aware that some practices will prefer to create their own, so they may not be standardized across the board. It's really important that you look for those numbers 965 and 967 or GPCCMP just to make sure that you know that they're on that new plan. Ensure that any new referrals, even ones that were written under a GPMP or TCA that have been received or like after the 1st of July, meet the new minimum requirements. Continue to provide services to patients referred prior to or on the 30th of June 2025 under the old arrangements as normal. Provide those services as normal until they run out or until the 30th of June 2027, and continue to provide written reports at the frequency requested by the referring GP. So I wanted to also touch on the digital health aspect of this piece. So I'm going to just talk briefly about that. So I'm going to talk about PRODA. So PRODA is an acronym. It means provider digital access, and it's the system used to access multiple online government services like HPOS and My Health Record. If you don't have a PRODA account, it is pretty vital that you have one, and it will get more vital as we move through. So you can click the link there to apply for one, or just go to apply for PRODA account. And then we have HPOS. So HPOS is it stands for Health Professionals Online Services, and it's an online service allowing providers to liaise with Medicare more directly. HPOS allows providers to do a lot in terms of their administration and checks for patients. Some of the features that HPOS provides are accessing online claiming. So you can lodge, monitor, and troubleshoot Medicare claims. You can apply for provider numbers. You can apply for initial ones and follow-up ones, as well as prescriber numbers. You can register organizational delegates. So this allows business owners and practice owners to delegate tasks to their staff if they're not the ones that are going to be doing all the billing, or they're not the ones that are going to do the eligibility checks. You can delegate someone to do that for you. You can manage your personal and organizational details, like your banking details, delegates, etc. Medicare correspondence will come through to there, and also access patient information. So you can access patients' Medicare numbers. You can look them up if you need to. You can check MBS item number eligibility. You can also use your PRODA and go through HPOS to access the National Provider Portal, which is the allied health or non-conformance software access to the My Health Record. So it's pretty vital to have a PRODA. The My Health Record, access to the My Health Record is provided to providers who don't have conformance software via the National Provider Portal. So I'll just go through the My Health Record briefly. The My Health Record is a secure online summary of an individual's key health information. An important element of the system is that it is personally controlled, and what this means is that an individual has a say as to what gets uploaded and what doesn't, what stays in their record, and who can also see their record. It forms part of a national system so that the individual's My Health Record travels with them wherever they are. And no matter which registered healthcare provider they are seeing, if they allow access, that can be granted to that healthcare provider. So who is using My Health Record? As you can see, GPs, pharmacies, public hospitals, specialists, and aged care facilities are using it at different rates. I would say that for allied health providers, probably the most useful ones are the GP and potentially public hospital. So when a record is uploaded to the My Health Record, when a document is uploaded there, it means that if you have access to the My Health Record and the patient's permission, you can retrieve that document, which obviously makes it a bit easier to retrieve lost care plan documents and referrals and even imaging. So if you have access to this, you're able to really provide your patients with like a very, very well-rounded, very like good, helpful service. So the types of documents that are uploaded to the My Health Record, personal health summaries. We have things like the Australian Immunisation Register, or AIR records. provider documents such as shared health summaries, discharge summaries, pathology reports, diagnostic imaging, and referrals are also uploaded there by GPs. So having access to that for allied health providers could be very useful. The My Health record can be accessed in 3 ways. If your organization uses conformance software, you can access the My Health record via that. Alternatively, if your organization doesn't have conformance software, you can access it via the National Provider Portal using a browser. So it's just a browser based site. And individuals can also share their information with you from the My Health app. So if you have a patient who tends to forget things a lot and they're pretty good with apps, try and get them to download the My Health app because it does keep everything in there. It is really secure, and they can download and actually email you the documents that have been uploaded to them, the ones that you need, and it makes it really easy. If you're interested in registering your organization for access to the My Health record via the National Provider Portal, please reach out to me directly. My details will be listed at the end of this presentation. So here we have some more info about the GPCCM. So a full item descriptor can be found on the MBS online website. You can also subscribe to future MBS updates by visiting the MBS online website. And there's also a link to the changes to chronic disease management framework referral arrangements. And last, we have some information about the My Health record. So there are some key requirements involved in accessing the My Health record as an organization. So again, if you are interested in that, please just reach out. And that's it. Thank you.
Well, that is fantastic, Grace. What a great presentation. And
Thank you.
I said to Grace, look, she can have at least 25 minutes. She's gone above and beyond that. So a really great presentation, and you nailed it. So well done. Now look, Grace, why don't you catch your breath for a second, right? And then what we might do is go to the panel a bit. Now look, John Petrosian, John's there, right? Great. So look, John Petrosian is the chair of the Central Eastern Sydney Allied Health Network. John, I just wondered, before we move into the questions, if you don't mind telling us, what is the Central Eastern Sydney Allied Health Network? How can people join, and why should they join?
Oh, fantastic, Brendan. Thanks for that. I didn't expect us to be able to sort of put a plug in there for the Allied Health Network. So as Brendan mentioned, I'm the chair, along with other board directors of the Central and Eastern Sydney Allied Health Network, which hopefully many of you have heard of now. It's a member organisation of CESPN, of our primary health network, along with another 5 GP networks and a community network. We do a lot of work behind the scenes to advocate for allied health, and among those is some of these webinars that are put on by CESPN. Sometimes we provide a bit of input, sometimes we provide a little bit of, hey, how about you put on a webinar for this or that? So if you're not a member of CESPN already, it would be great if you could. Our details are actually up on the CESPN's website, but I'll put it into the chat today. You can become a member. And we're always organising events and get-togethers for allied health. It can be a little bit lonely for allied health clinicians in the community. So we're an avenue for communication and a link to our PHN who provides services like today's webinar. Thanks, Brendan.
And I have to say, John's a very strong advocate for allied health, so it's kind of why we like having him around, right? Get a lot done. So thanks for that, John. I appreciate that. Now, look, we've got a few questions coming in on the chat. Now, Grace, have you caught your breath? You're right? All right. Great. Well, look, let's just have a look at a couple of the questions. So, well, what we might take can we take the last ones first, right? I know that sounds a bit weird. So some of the questions here are about, one of them is about how are allied health professionals supposed to keep track of the number of visits a patient will have in their clinics, especially for letter writing. So can I hand it to you, to Grace or Kayla? One of you can jump in and give us some advice on that, or Amy even, right? You guys choose. Right. Grace, why don't you start
I'm
off?
happy to.
Right?
Yeah. So basically the best practice for allied health providers going forward is to get your PRODA, register for HPOS, and have a system where you are making sure that patients that are, you could really look at it like this, patients that are not registered for MyMedicare will need to be checked, because you don't really know where they've had that referral written. You don't know who's billed it. You don't know, you know less about what's going on. Whereas patients that are on MyMedicare generally will go to the same doctor. You'll see the same names referring. You can be more confident. You probably don't have to check those patients as often, but it is good practice to check, honestly. So HPOS has an MBS online checker. Basically, you get a delegate of yours, so your receptionist or your practice manager, to be your delegate. That gives them access to be able to look up patients' eligibility for certain item numbers. So you put in the patient's name, plug in the item number that you want to bill them, and it will tell you if they are eligible for that item number as of right now. So that's how you check.
And it'll tell them like the number of visits that they've had and the number that's available to them.
So that one is a different section. Again, if the patient has the MyMedicare app or the Medicare Express app, that can also be seen in there. Yeah.
All right, great. Now, they're having not many referrals in the letter format, just only the paperwork for the CDM. Is this sufficient? And it's hard to use the CDM for referral date. Now, do you want to answer that question for us?
Me?
Yes, or
Oh,
you
sure.
or anyone. But why don't you start off with that one, and then
Look,
we'll throw.
My feeling about that one is I feel like it's probably not sufficient, only because it would be sufficient if the format was a form, but it hit everything in the minimum referral requirement. So I would say go back to the GP, let them know, actually it should be in letter format. Can you do that from now on? If they really don't want to, then I would personally want to find out what the answer to that question is, Rudo. Yes. But my
Yeah,
feeling is that as long as everything is being recorded, all the minimum referral requirements are there, it probably is okay,
Yeah,
but not
that's right,
ideal.
Grace.
right.
I think as long as the minimum referral requirements have been met, then it's okay to accept the referral. But if in this case it hasn't, then it would be best to wait and accept it as a letter.
You see, this is what happens when you get a panel of experts. Thank you, Kayla. Thank you, Amy, for that. Appreciate that. I think that's addressed that question. Now, just scrolling through these and keep the questions coming. We've got plenty of time tonight, folks. So we're all good on time. Now, so if really it's maybe John, you might come into this after Kelly, you might want to address the next one, and John, you might want to add to it as well. So if the number of sessions are not written, does that mean it's still capped at 5 across all allied health, or 5 sessions per discipline?
If the number of sessions is not written, it means that it is still 5 sessions across all allied health. The patient now has a bit more flexibility to choose how they would like to use those sessions. So as Grace mentioned earlier, if they have written that there's sessions for a physiotherapist and a podiatrist, the patient might choose how they like to split that up. So they might choose to spend 4 sessions with the physio, 1 with the podiatrist, or any combination of that. So it's really important to check in with the patient to see what their plan is and how many sessions of those 5 they would like to use with you, and then continue to check in with them to make sure that their plan doesn't change over time.
Yeah, so it's really empowering the patient to be able to make their own sort of care needs known, isn't it?
Just to add to that, if the patient were to see a physio A and they didn't end up liking that physio, then they could see physio B, but it always will be capped at that 5. But if they were to see the physio if the GP had only put 5 physios and they wanted to then see a podiatrist, they would need to go back to the GP to allocate the remaining ones to the different provider.
Yeah, okay. Good, thank you for that.
Brendan, if I could just add a few
yeah,
ideas
jump
as
in,
well.
John.
Yeah. So
great.
I'm feeling a bit of maybe uncertainty that might be sort of emerging from the allied health maybe watching tonight, in the sense that sometimes patients just rock up with a printed sort of referral. That's how they have done in the past, and say, oh, g'day, I'm here. I've got my referral from my GP, and they've given me 3 sessions under your care. So I suppose this is probably an opportunity where you need to revisit some processes in the practice. Sometimes patients just book themselves in online. A lot of us have got online booking systems. And they may not necessarily say, I'm booking in under a, for the new system, a GP CCM. They'll just book their initial consultation, and you'll almost feel obliged to give them the session, even though they've got uncertainty whether that patient's actually under a plan, because they may not have received the letter under this new scheme, which means that you might just need to, I think, speak to Grace and speak to CESPN about getting your practice or understanding how to register your practice with under PROTA with HPOS, and instilling a little bit of a new system within your practice booking system, so that it's clear that if someone's booking themselves in as a new visit or initial visit or any sort of visit, if they're coming in with this GP referral, that in fact you have a copy of it before they come in. And the only way that you're going to have a copy of it is that if your practice is set up with HPOS and you're able to access that patient's MyHealth record. So there's probably some compliance things in there in terms of having access to the patient's Medicare number, name and date of birth. It just means that you might need to ask your receptionist to screen them when they're first booking in. If you don't have a receptionist, you're doing that yourself, then having the conversation when a person's booked in that you're not familiar with, to really ask them, can you send me a copy of the letter that you have from the GP? And just to keep it simple, the letter that the GP is going to send you is pretty much similar to the letter that you send them, but it's going to have the addition of their provider number, the date of the referral, their practice address, the reason for the referral, and hopefully the GP also writes the recommended amount or number of allied health visits that they're asking the patient to come and see you for. But we all know GPs are busy and they may not write that number in. So that's where it's, I suppose, even more important for you to have access to that patient's MyHealth record, because you'll have their referral will be sent on MyHealth record, as long as the patient's opted in for that or hasn't opted out. But I think as allied health clinicians, especially in private practice, we can be a bit isolated. I think this is the opportunity now to upskill your practice, get it digitally connected, because within 2 or 3 years, secure messaging will be the way that we communicate, rather than through other means. And HPOS and PROTA is not going away. It's getting accessed and utilised even more. So I think that sense of confusion that you might have in the sense of, well, how many visits am I providing this person? Is this the first? Is this the last? Then that information will be given to you from the first point of source, hopefully, which is through HPOS and MyHealth record. If it's not, if the patient isn't registered with MyHealth record or doesn't allow the GP to upload documents, then you'll need to ask the patient to really bring in that form with them, the letter from the GP, or preferably send it in before their visit, just to because otherwise, I know you're all busy in practice and you can't be sidetracked with unknowns with these sort of situations. Otherwise, it'll set you back, half an hour for your next patient.
All right, that's great, John. A bit of practice wisdom coming out there from John. So I think that's really practical advice. Thank you for that. And I think someone's just wanting some clarification. Is the maximum number of sessions available under the new plans 5 sessions in a calendar year? I'm seeing some nods. Does someone want to jump in? Amy, do you want to jump in?
Yeah, so it is 5 per calendar year. It's not 5 per referral or 5 per 18 months. It will be the 5 per calendar year. And if they are wanting to, again, get an additional 5, it would be the next calendar year that they'd be able to see their GP to get that new referral.
All right, thank you. Now, we might go back to you, Grace, which is if a patient goes to a podiatrist and an occupational therapist, do both professionals need to provide an initial letter to the GP and an ending one?
I would say yes. like if I was the practice manager of your allied health clinic, I would be wanting both sent personally. But I don't know, does anyone
I can
else?
jump in there.
Okay,
Yeah,
great.
Grace. Yeah,
Yeah,
that's
or
correct. So
Kyla?
each allied health professional will need to write an initial letter to the GP and a final letter to the GP. And that's, I guess, just allowing that intercollaboration between the GP and between the allied health professionals so that, especially if the patient is visiting multiple different professions, that the GP can have a bit of a picture of what's been happening for that patient in their sessions. And that will really help them when they're going to do their reviews to see, you know, do they need more sessions referred to this particular profession, or is there anything else that they can do to help support the work that you're doing as well in your practice?
Yeah. Thank you for that, Kayla. And John, I just might want to come back to you now with some input. We are getting a few questions around simply about trying to find out the number of sessions are available. It's making people are finding it difficult to keep track of things. Do you have any practical thoughts, or Kayla, do you want to provide some additional thoughts on that as well, around how many sessions are available, how many people have actually, when someone comes, maybe they've already had 2 sessions. Right? How's the practitioner supposed to know?
Yep.
Find out efficiently, right?
Yeah, and I noticed quite a few comments in the Q&A there about that, and it's a point of confusion and possible confusion. So, and there are some great clinicians on that list. I know many of them. In the past, it was fairly simple. We had a printout, or we could put that into our clinical records because it was numbered. It was a numbered item on there, like you've got 5 sessions or 4 sessions or 3 sessions. So we knew when to write our initial and our follow-up or discharge letter to the GP. I think it might be a little bit of sort of discussing with your team to figure out from your patient base and the sorts of people that come to see you, what's going to work best for your practice. So if it's an older population that's coming to see you predominantly and they're being referred with these new plans, they may not be digitally enabled themselves, which might be it might actually be easier for you in a way, because they'll come in with a printed form, and often they may also be a bit more organised and let the person on the telephone know that they're coming in with a plan as well to preempt that. Then I sort of read a little bit in terms of what's going to happen in the next maybe 3 to 6 months. There's a lot of education that's going to come out from the department in terms of what do we do with these plans, and also these new apps that are popping up, which Grace mentioned before, which were the My Health app, the National Provider Portal, PRODA. I think there's going to be a lot more education pieces coming out from the government to help us all, not just clinicians, but consumers as well, so that they understand how to use these services. And I think one of the stats that I think, Grace, you had up initially that I suppose preempted or spurred all these changes on was that 30% of those referrals out to allied health were not getting redeemed. So, if there's 100 referrals that are being made, Medicare paid for 100 referrals initials, but only 30 of those were going through for care. So, if the outcome is that it improves patient outcomes and improves, the budgeting outcomes of this, it's going to be beneficial. So, I think as clinicians, have a chat to your team, figure out what processes and workflows are going to be best for you, all the way from what do we do when we get a telephone call or we get a new booking from a new patient. Does it mean that we need to contact that person before they come in? It might be your sort of method of initiating contact now. But if it is, ask them the question, are you coming in as a private patient or as a GPCCM plan? Just to clear out that confusion. And then unfortunately, you'll have to upskill to understand what this HPOS thing is and what PRODA is, so that you can access My Health records a little bit more frequently, because it's the minority of allied health are accessing My Health record at the moment. In actual fact, we don't really have a minimum standard document that we can upload information to My Health record yet, but I understand that that some of those are happening. Some of those changes are happening at the commission, at the Commonwealth level. That they've been advocating for a minimum data set upload from Allied Health, and that could be, you know, a podiatry session, it could be a physiotherapy session, it could be a psychology session, you know, a short statement of what that person's come in for. You can actually upload that onto My Health Record as well. So the scope is going to increase for everybody. It's just getting over this little hurdle first of upskilling.
Could I also?
Yeah, it's a bit of an invitation type issue, but jump in, Grace.
I was just going to
Okay.
also say that I think it would be really valuable to try and take advantage of the patients that you know are registered for MyMedicare and developing that relationship with the practices that are closest to you that are registered for MyMedicare that are going to have that continuing continuity of care with your shared patients. And you know what? If it comes to it and you say, you know, I'd prefer it if you did list the number of services, I'm sure they would do that because you're a regular referrer, right? So making sure those connections are there and like strengthening the whole community would be a really, I think, a really good way of getting that kind of confidence.
Some great advice there, Grace. I think that's right. Developing those relationships with your referrers is always a smart thing to do, I reckon, if you're in Allied Health. Now, did one of the other panel members jump in there?
Yeah, I was just
Kayla,
going to,
jump in.
related to what John was saying about My Health Record as well, and I can see we have a question about who can help patients with registering for My Health Record. I just wanted to let you know that over 90% of Australians already have a My Health Record. The way that it was set up is that people had to opt out. So unless a patient has chosen to opt out, everybody already has a My Health Record created for them. And if they are somebody who likes to use digital technology a little bit more, they may have it as an app on their phone. So they'll be able to quickly log in and show you anything that's been uploaded, or you can also access it through the National Provider Portal. So almost all of your patients, more than 90% of your patients will already have a My Health Record, and there'll be lots of information being uploaded there that you'll be able to access to help you provide better services for them.
You know, if I ever get stuck trying to program my TV, I know which one of the panel members I'm going to. Probably all of you, quite frankly. Now, look, there's a question in the chat around how do international students access Medicare rebate?
Yeah. Yeah, excellent question. I actually haven't looked into this specifically. It acted the same as Medicare. So in terms of the GPMP and TCA previously, a GP could bill Bupa, an OSHC Bupa, for a 721723 that would then get paid by Bupa, which would then open up the sessions for Allied Health for the international student. I'm going to confirm before I lock it in that is the same. I can't imagine it's changed, but I will confirm and get back to you. But yeah, excellent question.
Yeah. All right. Some things are still being worked out, right? Now look, the patient, I think we've covered off some of those. Now, there's been a comment that's been made, which is we're seeing more referrals for less consults. But then another referral, for example, 3, but then another referral for 2 more without a gap in the course of treatment. We're treating this as 2 referrals, so 2 letters for the initial consults and then 2 final letters. Is this correct? John, I'll come back to you. If I can just leave you for a minute, John, but then I might come to, who wants to jump in there, guys? Is it Grace or Kayla?
I'm happy to jump in there.
Yeah.
Yep. Yep, great.
I think a reason why you might be seeing that as well is because the department is trying to encourage GPs to do more of those reviews. So in the past, they may have just done an initial care plan and then given all 5 referrals and then waited for the 12 months and then done an initial care plan again. Whereas now we're seeing more and more GPs reviewing their patients every 3 months. So they might only refer for 3 sessions, like you mentioned, or 2, and then wait 3 months until the patient comes back in again, just to check in and see how things are going before they give the other referrals. So I can see why that's been happening more and more frequently. And I will have to double check with you in terms of the initial consults and 2 final letters. I believe that you would have to do 2 separate ones, but I'll have to double check and get back to you on that one as well. That's a good question.
Yeah, I was just going to add, Kayla, thanks for that. That the initial and the final letters are definitely recommended as best practice to do. But yeah, with the 2 final letters, we'll check that for you.
Yeah.
Yeah, guys, we've got another 5 minutes or so for questions. So if you've got questions, put them in the chat because we're running right on time here. So still got plenty of time for some questions. Now, John, I'm going to ask you a question, but we might keep things fairly brief, which is, how do you think these changes will impact allied health, and how should allied health respond to them?
Yeah, good question, Brendan. How will it impact? I think initially there'll be some teething problems, particularly just with pragmatic things of, like we mentioned before. And what it's going to do is actually help just springboard allied health into sort of the a bit more of the digital age. It'll force us to use these portals that have been developed, and GPs have been using them for a while. I know a lot of allied health are using them, but there'll be more allied health that will need to use them. And I just want to also just mention secure messaging is another portal that needs to be used by more allied health as well. It is a paid service. There's an annual fee for using secure messaging, but with secure messaging, you know that your letter has gone to the GP because you can access, you know, the GP's provide number. So once you send a letter through secure messaging or HealthLink, it gets sent straight to the GP's inbox, and you know for sure they've received your letter. Sometimes with post, we're not sure, because often allied health don't receive letters back from GPs. It's usually one-way communication, which that's just the nature of the beast. And fax machines has sort of phased out, and we're not meant to be sending patient details through email. So secure messaging is the way to go. Unfortunately, we don't really have, on the whole, programs that we're running in our clinics that are conformant with secure messaging. So you will have to have quite a few portals in your practice, maybe pinned to your web browser. You're going to have your practice management system. You'll have Proda pinned. You'll have secure messaging pinned. You'll have My Health Records pinned, just to start streamlining a few of these processes. Otherwise, you'll be forever sort of scrapping around your desk trying to find that web page and website and email and username and password to get in. So, yeah, that things have to change at the moment.
Thanks, John. Now, look, one of the my takeaways from listening to Grace's presentation is a lot of acronyms, right? There's a lot of technology involved, right? And that's all well and good, but you know what? If I've got, you know, two left thumbs and I don't quite know how to work things, where would allied health go to for a bit of support and advice around these changes? Can I just throw, particularly to the assessment panel members, can I ask you guys, what should people do? Who would they go to, right? Because all of you have got slightly different roles, but you all work in this space. What should they do, all right?
Well, I'm the digital health officer, a digital health officer, but I have a bit of experience with allied health and GPs,
Great.
so I
Great.
guess yes, me.
So it's Grace, and then Grace has got some good backup with Kayla,
Yes.
and Amy, because I think we're getting a few questions now, aren't we? We're getting more and more inquiries, and we're fortunate we've got a lot of allied health in our region. So just help me out on this, Grace, which is, maybe you can post it in the chat, which is, how do people contact CESFIN if they want some advice?
Wow, that is a good question. My email address, I will pop in the chat.
So we might be able to send through the digital health officer, the digital health email address, and also the practice support officer address. So we'll make sure that's circulated. All right.
Yeah.
And you guys are pretty, from what I understand at least, you guys are pretty quick at responding to allied health. Is that right? Yeah. Yeah. Good. Go, Grace.
I think I am. Yeah.
Yeah.
I've gotten
Good.
a few
are.
practices onto the My Health record already. So
I think what I was having a chat with Grace in the office the other day. She said the harder the question, the better. Right. So bring it on. We look forward to responding to that. Now, in terms of were allied health consulted during the process of planning these changes, look, John, you can probably speak to this, but absolutely allied health were consulted. But I think there's probably some of those initial sort of teething implementation type challenges as people get used to new systems and processes. And, you know, that's not unreasonable, I think. Hopefully they don't persist after 6 months. But John, any tips for allied health providers who are feeling, you know, understandably a little bit confused from a practitioner, allied health practitioner? What are your top tips for how they should respond?
Thanks, Brendan. Top tip would be get Grace's email address. Thanks for that, Grace. I really appreciate you being the contact person for allied health at CESPN. Because what Grace will be able to do is, if your practice isn't set up with these portals that you're going to need to access, Proda, they'll set you up with Proda. They'll set you up with, you know, getting your organisation identity number, which you're going to need. You're going to need a practitioner identity number for yourself if you're practicing in there, as well as all the other practitioners. You're going to have some delegations set up so your receptionist can access HPOS as well. At the beginning, you might think, oh my gosh, this is so much stuff to do. But once Grace sets you up, just sort of sit with that for a while and do as much reading as you can, particularly maybe, Grace, if you can pop the that website link on CESPN's website, where there's a lot of information already developed, fact sheets developed for allied health. It sort of sets out a map that you can sort of then read, understand, and then sit down with your team at work and figure out, like I mentioned before, a flow plan or a procedure of what are we going to do when we get referrals, and set some scenarios as well. That what if a practitioner doesn't know how many GP visits have been allocated? Then either ask the GP or develop them in consultation with the consumer, your patient. But these are conversations you may not have had before, and as part of I suppose, a consumer or a patient-centered practice, these are the sort of conversations you need to have, because the care does revolve around the patient and their health goals. So take it easy when you're implementing the changes into your practice. It's not going to be perfect the first time, so take the pressure off yourselves. You may make a few mistakes here or there. Just document them. If you forgot to write an initial or a discharge letter to the GP, don't stress. Just document that it was missed and may have been because of teething issues with the changes that are happening at the moment. But set yourself a goal and a plan that, you know, within the next 3 to 6 months, you've got a solid process in your practice of identifying and processing patients adequately. That because if you're, or, you know, when practitioners get audited, not just GPs, but allied health, you know, they're asked by Medicare, can you provide your letters for these patients? That, you know, it's a simple process. It's just downloading them as PDFs off your system and sending them off to Medicare. So just set yourself a goal, 3 to 6 months, and you'll be right.
All right, good. Now, panel, are you ready for the last couple of minutes? We're going to have some rapid fire questions, some really rapid fire questions here. Is there any updates for HealthLink for allied health professionals? Is it free for allied health professionals yet, or is it still only for GPs? Who wants to take that quickly?
I feel like that's a John Petrozzi question.
John Petrozzi, jump on in. Quick answer.
Yeah, there's an annual fee. So yeah, you would need to contact HealthLink and secure messaging. Maybe that link can be sent to everyone once they receive their CESPN certificate, Grace. That'd be really, really good. I think GPs have a separate sort of situation. They pay or don't pay. I'm not quite sure how it's working at the moment, but we do have to pay. We've been lobbying them for a while to not pay, but, you know, at the moment we need to pay. So, and it's quite reasonable for the year.
All right, good. Thanks, John. Does a client need to do anything to allow you access to their My Health record, or is it just a case of them providing you consent?
So if you're seeing the patient as a healthcare provider, the client doesn't need to do anything to allow you to access their record. You're able to access it if you're providing them care. The only time that might not be true is patients do have the option to apply a passcode to their My Health record. And in that case, you'll have to be with the patient and ask them for the passcode before you're able to look into it. But that just depends on how the patient would like their information to be set up.
Okay,
And
now we're going to go over time by a couple
sorry,
of minutes. But
it is worth also
in.
mentioning that My Health record patients can set have a setting turned on that allows them, notifies them every single time anyone accesses their My Health record. So do not access the My Health record until you have gone through the process with me to set up a procedure and policy about it, please.
I think you guys are going to be popular out there in allied health because you'll be getting quite a few calls. Now, look, we're going to go over time by a couple of minutes. I don't think people will mind. can the CCM sessions be in addition to other sessions provided under other plans? All right, who wants to jump in?
I'm happy to jump on this one.
Amy? Yep.
If they are receiving 10 sessions under the mental health care plan, they can also receive up to 5 additional from their allied health professional, as long as they are clinically relevant to their chronic condition.
Great, thank you for that. Now, look, I think we are pretty much at time, and I think we've answered pretty much, from what I can see at least, most of the questions. Can I say this won't be the only education session for allied health? We'll be running more. It's really important, and we are really, we really want to support allied health in this change. Can I thank the panel members? Can I thank Grace for, I think, your first solo presentation tonight? Well done, Grace. Good one. Well done. Can I also thank the other panel members, Kayla, Amy, and John? I appreciate your input tonight. Now, look, just a reminder to complete the online survey that will pop up in your web browser. And we look forward to seeing you at the next online CPD session soon that Seston will host. So have a good evening, and thank you for attending for tonight.